Okay, well, we might get underway. Welcome to the second of our Smoking Cessation Professionals Update Days. My name is Nick Zwar and I'm co-chair of the APSAD Smoking Cessation Special Interest Group, and it's my pleasure to chair the first session. And I'd like to start by acknowledging the traditional custodians of the various lands on which we meet today, and Aboriginal elders past, present and emerging. And that welcome acknowledgement of country is very topical as we have a focus on smoking in Aboriginal and Torres Strait Islander people as a big part of today's program. And some wonderful speakers on that topic for you to learn from and to interact with. As has been said on the just the slides that were introduction, you can ask questions via the system, and we'll attempt to put those to the speakers as we go along. I think given the pressures of time and we've got lots of people online already, I might start by introducing Professor Tom Calma. Tom has a long and distinguished career in social justice and community development. He's Chancellor of the University of Canberra and National Coordinator for the Tackling Indigenous Smoking program of the Australian Government. He served as Race Discrimination Commissioner from 2004 to 9 and former Aboriginal and Torres Strait Islander Social Justice Commissioner with the Australian Human Rights Commission. Tom is an Aboriginal elder from the Kungarikhan tribal group in the Awadji tribal group, whose traditional lands are southwest of Darwin and on the Coburg Peninsula and the Northern Territory, respectively. So welcome, Tom, and Tom's going to talk to us, give us an overview of the Tackling Indigenous Smoking program as a starter for today's webinar. Tom, you're still muted at the moment, so you just have to unmute.
Very good. Thank you. Yeah, I got that little message. Yeah, thank you, Nick, and I hope you can see the screen okay. Can I begin by recognising where I am in Canberra, the Ngunnawal people, and pay respects to elders past and present. I'm from Darwin, Kungarikhan on my mother's side, Iwaja on my father's side, and we got a very special week this week, which is NAIDOC week, and so I'd like to recognise all Aboriginal and Torres Strait Islander people who are participating on this webinar today, and your countries always was and always will be. Okay, so yeah, as Nick mentioned, I'm firstly very appreciative that we've got a focus on tackling Indigenous smoking, as this is something that I'm very actively involved in as the national coordinator. So I want to talk a little bit about the TIS program in about 15 minutes, and that'll lead on to two of the other presenters, Dr. Gillian Gould and also Dr. Raglan Maddox, who are part of the TIS program and will give a presentation. But in essence, currently we're in the third year of a 4-year program. Minister White back in 2018 announced $184 million to the Tackling Indigenous Smoking program. It was a program that was building on what happened in the past, but for the first time we had a guarantee of 4 years funding. We had stable policy and you know, stable funding, which really did lay a foundation, I think, for the future. And we're in the process now of starting to encourage government to think about funding for the next decade or so, and even more, because that's how long it will take to be able to really get Aboriginal and Torres Strait Islander smoking to be down on par with the rest of the population. This slide just talks about some of the elements of the TIS program, but I'll go into that in a little bit more detail in a second. One of the key things about the TIS program is that it's a population health approach, and the government's saying is that the Aboriginal community control sector, they're primary health care, and they should be doing the direct intervention with their clients, one-to-one smoking cessation type activities. the TIS program is really to get the message out to the community about, not taking up smoking, or if you are a smoker, to give up, and then point out where all the resources and support is available to be able to do that. We're also got a national coverage, and the other, I guess, key thing is that the TIS workers work with the non-AMS clients. They work with the general population, which is very important in the sort of work that we do. Now, the TIS program is for $184 million, you'd expect it to be a little bit complex, and it has a number of components. Myself, as the national coordinator, and I've been involved since 2010. I do this only 10 days a month on this project, and take a mentorial and leadership role, a bit of a bridge between the community and government and politicians to keep people focused and supported. The program has the support of a national best practice unit, which is a unit that's externally funded or funded out of the program, but to a non-government source to build the capacity of the 40 teams who are all over Australia. And so to help them understand about the directions of the program, but also the importance of data collection, of being able to stay focused, learning about resources that are available to help undertake their role, etc. There's also, we fund Quit Skills and Quitline. Quit Skills project through Cancer Council SA is really about a service that we provide to communities and to organisations around the nation. It's a free service, and it's where Quit Skills will go in and train up people on how to do brief interventions, how to develop up policies within their organisations, and generally, information about the Quit Skills program and how it complements the TIS program as it currently exists, and the various elements. And of course, Quitline, which are funded by states and territories, governments, or mainly state governments, but we have an element of that which is an Indigenous Quitline service, where we fund Quitline counsellors, Indigenous counsellors, but we also provide cultural competency training for all Quitline counsellors to encourage people to utilise the services as it goes along. The department also has a strong relationship with the states and territories, the federal government, to try and ensure that we do have a bit of a coordinated approach wherever possible, and also that recognising that this is not just a Commonwealth initiative, but it's a whole of government's initiative. But I think what's really strong in this whole program are the evaluations, and we sort of embedded this more recently in this last tranche of funding, but it's all about making sure that we do have a clear understanding about the impacts of smoking, and I'll touch a little bit on that in a second. But we have a number of priorities, 6 major priorities. They're all listed there, and but it's about partnership collaborations. It's about the support. It's about addressing secondhand smoking. It's not just to try and educate people about the impacts of cigarette smoking. 2 of the other major focal areas are on pregnant women, and we fund the SISTAQUIT, and Gillian will talk a bit about SISTAQUIT and I guess on SISTAQUIT and how they fit together, and some of the objectives of that. And for remote populations in particular, we've got to get the reach out there, and Raglan will talk a bit about this. Whilst we have seen really positive outcomes so far in smoking cessation, it's more evident in urban and in regional versus remote. So it still becomes a big priority area. Just on evaluations, there's 2 parts to it. One is Circa, who are what we call Part A, that's really a national evaluation, and that's working with really looking at as it says, implementation, appropriateness, and outcomes. And so it's an internally focused one, looking at the teams and how they go about their business, and they'll be conducting this ongoing evaluation through site visits, the phones, surveying, and really drilling down on each of the elements, because we want to make sure that at the end of the day, this is an effective program that should continue to be funded as we go along. Part B, which is the part that Raglan will talk about, and that's a second part that ANU's funded to do, and they do that in conjunction with Menzies, and that's looking at the overall impact of the TIS program, and also looking at how other programs might enhance the impact of the TIS program. So that's really, in essence, where the two lots of evaluation, an internally focused one and an externally focused one, the Raglan one, which is really big data versus the end KPIs that all AMSs fill out, so that we can get a good understanding about the impact of our services across communities and how we all work together in this program. Just for reference, is that we have what we call a TIS portal on the Health Infonet website, one worth going to. This is basically what it looks like. There's quite a number of elements to it, but it's the go-to place if you want to find out anything about tackling Indigenous smoking. It has plenty of resources for both externals to have a look at, but also as a resource centre for all of our workers, because there are 40 teams across the nation, and some are really regional focused and remote area focused, others are urban. So we all have totally different approaches, but there are commonalities, and the whole thing, about the beauty of this program, I think, is that it is really focused on place-based. So if it's working, let's exploit that. If it's not, let's work out how we can change it. So on this website, and for all the viewers who are not TIS members, you're welcome to go to it, and the information is all there. And there's a lot of resources that we develop, be they videos or fact sheets or other resource information. They're just the sort of areas that we cover off on. And as I mentioned, mums and bubs is a big priority. We don't have in the Closing the Gap targets a target on reducing smoking, but we do have one on healthy birth weights. And we know that smoking impacts across a whole range of areas, including healthy birth weights and also healthy births in full stop. So all these sort of resources are there. We ran a very important roundtable earlier in the year on smoking and pregnancy, and brought together a lot of the majority, I'd say, of Indigenous researchers in this space and other players, and it's very effective. And the outcomes of that roundtable is also on this website. So, thank you for all your interest in this area. We're available as TIS teams around the nation, and myself, if any of the listeners want to have a chat later, feel free to do it. So that's it from me.
Thanks very much, Tom, for that wonderful overview of the Tackling Indigenous Smoking program. I'll give it about a minute. So can I ask you, so there are 40 teams across the country. Does it cover the whole of Australia, or is it sort of focused on regional and rural Australia or areas of higher prevalence? How did you decide to place the teams?
Well, it went out to open tender, and people applied for it. We tried, in theory, it covers all of Australia, from urban to the very remotest areas. What we've identified in recent times is that there are certain areas that are being missed. Well, you know, I wasn't going to say it, but I will say that we're about to launch an app. Hopefully, we hope this week, but it may not be. It's one that will identify all the TIS boundaries around the nation. But this interactive map also gives you, within a region, the populations, all the Aboriginal organisations that are there, all the health service providers, etc. So it'll become a one-stop app that anybody working in a regional area will be able to know the sort of, you know, the target areas, the priorities that they might have. But it'll also be very useful, I think, for anybody else working in a, you know, a regional area. So hopefully that'll go out very soon. But the department has developed up that app, and yeah, it'll be there. But in theory, yes, everything is covered. In practice, we've still got to expand the activities of some of the teams to make sure that they do service their full regions.
Great. Well, thanks so much again, Tom, for that wonderful introduction overview. And I'll hand over to Jenny Minshall, who's going to chair the next session and introduce Associate Professor Gillian Gould.
Thank you.
You're on mute, Jenny.
Unmute. Okay. Hello, can you hear me now? Great. Thank you very much, everyone, for attending today. This is my greatest honour to introduce Professor Gillian Gould. This is very exciting. We're all very keen to hear what she has to say. So, Associate Professor Gould is a GP and a tobacco treatment specialist with a wealth of information and clinical experience about assisting smokers to quit. Her research focus is to improve the risk from tobacco smoking among Indigenous Australians. So we really appreciated that. As Gillian is in the NHMRC Translating Research into Practice Fellow, co-funded by the Cancer Institute of New South Wales at the University of Newcastle. The fellowship will improve strategies for pregnant Indigenous smokers. She has co-developed over a decade strategies to tackle smoking with Aboriginal communities and led a regional Indigenous tobacco control initiative from 2010 to 2012. Gillian supervises 5 high-calibre PhD students at the University of Newcastle and leads a multidisciplinary team for the National SISTAQUIT Supporting Indigenous Smokers to Assist Quitting program and research project, and the implementation phase of SISTAQUIT. Other projects include co-developing the multi-behaviour change Mama Empower app for a healthy Indigenous pregnancy. This is fabulous work, Gillian. We're very excited to hear. So without any further ado, I will introduce Gillian. If we have time for questions at the end, that will be great. Otherwise, we will try and share out some of the answers to those questions. So I'll hand over to you now, Gillian. Thank you.
Great. Thank you. Just get my PowerPoint going here. Yes, thank you for the very warm introduction, Jenny. That was lovely. I'd first like to also acknowledge the traditional owners of the Indigenous lands across Australia, really, where our program is national, and pay my respects to all Indigenous people on the call today, and also acknowledge my great and dedicated team of Aboriginal and non-Aboriginal researchers. And just my disclosures are there with the funders. I don't take any funding from big tobacco or pharmaceutical companies or vaping companies either. So a little bit about the background. I guess most of you probably know a little bit about smoking in pregnancy. It does cause a whole raft of problems, not only for the babies, but also for the mothers themselves. It is a really important area, and it is a high priority focus for the Australian government and a lot of the cancer programs across Australia. Prevention obviously is very important. And we know that smoking cessation does help avoid those acute and chronic health conditions. And some of those chronic health conditions can follow the child throughout the whole lifetime. So we know that about 43% of Indigenous women in this country smoke, and that rate has come down, but there is need for more to be done and more tailored approaches. And there is a whole background really of why those rates are high, and a lot of it goes way back to colonization, dispossession, and racism. But those processes are still ongoing today. They're not kind of finished with, and a lot of things that do impact on that system level. And yet we still know little or not enough about what works for Indigenous pregnant women. There have been some trials done in both in Australia and overseas, only about 4 randomized trials to date, but they haven't been able to show a significant difference yet between intervention and control. But we know one of the barriers also is on the health provider side, that health providers, particularly when it comes to what to do when faced with a woman who is smoking during pregnancy, they're really lacking confidence and skills and training. But pregnancy is such an important opportunity because you've got that chance to influence 2 people at least. So I just want to talk a bit about, just as a way into the programs, why we developed this. We did a survey of GPs and obstetricians in Australia to ask them about what they offer women who smoke in pregnancy. And this was across the whole nation. It was 378 sample. And you can see from here that we're quite good now at asking and advising people, maybe even assessing motivation to quit. But as those things go down on the bar chart, you see it gets lower and lower, and particularly low with assisting with nicotine replacement therapy. And, surprisingly low about following up or arranging referral. And then we went a bit further and thought, well, let's do a systematic review, which was over 54 countries, 54 studies in 10 countries with a broader range of health professionals. Like this includes all health professionals, including midwives and dentists, Aboriginal health workers. And you can see it's almost the same graph. I sometimes have to think, have I got the right graph in here? Because it's a pretty well identical picture to what's happening here in Australia. So we're not alone. And then, this is on the basis of which we developed SISTAQUIT. So it was a phased development. It's gone over quite a few years, but this is actually quite rapid compared to how long a lot of projects do take. In phase 1, we co-produced and pre-tested our resources, which were co-developed with 2 Aboriginal services in Hunter, New England. That was Biripi and Toowoomba. And we pre-tested those resources out in 3 states. And then we developed a pilot study, which was I Can Quit in Pregnancy, which was piloted in 6 Aboriginal community control services in the 3 states. That was Queensland, New South Wales, and South Australia. And then we went on, and that was a feasibility, acceptability type study. It was a step wedge randomized design. Then we went on to get funding for SISTAQUIT, the original SISTAQUIT, which is an RCT of webinar training versus usual care in 23 services now. And we're about halfway through that. And I'll talk a little bit more about that. But at the same time, we were offered this fantastic opportunity from the Department of Health to implement SISTAQUIT further, which is our phase 4. And we're looking at 20 to 30 services now for that. And we're also already looking ahead to, well, what would national scale up look like? Is there a potential of adaptation internationally for this study? This slide should have come before, sorry, the other slide. But as part of our systematic review research, we did actually do a qualitative systematic review, which was on 29 studies in 12 countries, and this is under review at the moment. But looking at the behaviour change wheel and capability, opportunity and motivation of health providers to provide this, advice and help and assistance to pregnant women. And, you know, there was a fair degree of that they were affected by role confusion, lack of time and training and resources. The increased metabolism of nicotine in pregnancy means that there are kind of some nuances around dependence, where you have to actually provide more NRT than you would usually, and that leads to quite a lot of uncertainty in the health providers. And you know, women's motivation to quit is quite dependent on, you know, whether us as health providers explain the risks and benefits and have that conversation respectfully. However, women do actually consider, you know, advice from health professionals to be really important and effective, but it's got to be accompanied by, you know, appropriate resources, peer support, feedback, a lot of positive encouragement. So there's no shortcut really to this. So I've just got to find my little arrow. Oops, hang on a minute. Here we go. So look, going back to SISTAQUIT trial, this is the RCT. Our aim is really to improve health provider behaviour in the delivery of smoking cessation care to pregnant Indigenous women who smoke. So we're wanting to hopefully see an increase in smoking cessation rates among the women who are enrolled in the trial, particularly hopefully those who are attending services where the training has been delivered. The control group is usual care. And we also want to improve health provider knowledge, skills in providing that care. It is a pragmatic hybrid type 1 cluster RCT, for those who like to know a bit about the methodology, with both outcome and process measures. So there's an awful lot of things we're measuring here. But it is the first national trial providing smoking cessation care for pregnant Indigenous women to follow up both women and the baby's health together. And so we're recruiting mostly Aboriginal medical services, but also some mainstream services into the trial. And they either get the intervention, which is the training and the resources now, or they do their usual care, and they will get the intervention later at the end of the study. So we're asking each study to recruit about 15 women who are either Indigenous themselves or pregnant with an Indigenous baby, who are 18 or over and less or equal to 32 weeks gestation. And what they get with the intervention is, at the moment, they get a 3-hour webinar training, which is actually delivered on site where possible. They get a treatment manual, a flip chart, a mouse pad, which is like an algorithm, for the health providers. So women get a booklet, and inside that booklet are augmented reality videos they can look at. They get free NRT, and we train research facilitators at all sites who are going to help collect the data, who are part of the usual staff. Now, we do use an ABCD approach. Now, ABC approach was popularised in New Zealand, but is used also, has been used in England. Ask and assess, brief advice, and see cessation. And it's supposed to be a bit easier to remember and see, like, you get to the cessation, you know, quickly, and talk that includes behaviour change techniques and NRT. But for this, we added a D, which is discussing the family, social and cultural context, the psychosocial context really, which is very, very important, I think, for everybody, to be honest, but particularly so with Aboriginal and Torres Strait Islander women in pregnancy, because of all the kind of other factors that come into it. And we have published this, my co-authors are Renee Batoon and Marilyn Clark. It's published some time ago in 2015. So for this trial, we're hoping for a sample of 300 women. So as I say, the research facilitators collect the data on site. Our primary outcome is carbon monoxide validated abstinence at 4 weeks, but we also are following up abstinence all the way through to 6 months postpartum. We're looking at birth outcomes of the babies. We're particularly looking at the baby respiratory outcomes monthly up to 6 months. And then we're looking at health provider knowledge, attitudes, behaviours. We're looking at some fidelity measures, audio recording, some of the consultations, recruitment and retention rates, and how much NRT is provided. So like some of our challenges with this trial have been that, you know, the consultations with Aboriginal communities have been lengthy, and it takes time to get those permissions. We have multiple ethics committees. I think we're about 12 now. And we have high staff turnover in the services. And we've had to retrain quite often with the research facilitators up to 4 times sometimes, or up to 40% of sites have required the retraining, and up to 4 times. And there has been actually lower than expected pregnancies in remote areas, and a good thing, sometimes lower than expected amounts of smokers, and that's a fabulous thing. And we have been delayed with COVID and wildfires and floods and you name it. But we've got about 100 health providers in the trial. We've so far got about 80 women and 10 babies. Not all the women are consenting their babies to be followed up for various reasons. And we've got 22 services, and most of them are rural and remote. And we've now had an extension of the trial to March 2022. So we hope we'll be able to limp towards our sample size. We did a little bit of preliminary analysis on the baseline of 56 women, and we found some interesting things which are not unexpected, but women were more likely to want to quit smoking if they'd had education past year 12 and if they have a baby or a child in the house.
Excuse me, Gillian, we've just got to move things forward a little bit.
Okay, sorry. Hopefully not too long. Anyway, we'll come on to SISTAQUIT now, which is our implementation phase. And we've got over 40 services interested and 25 ready to sign up. So all sites are going to get the training and resources. The training's gone on to a self-paced e-learning modules, and the services will get communicator or medical director templates to record the data. They will, these are some of our resources here, and this S thing is our e-learning modules. So instead of recruiting the women one-on-one, they'll be recording the data from the women on the medical software templates. And we are doing an SISTAQUIT social media campaign to go with it, and we'll be filming that out in 5 locations across Australia, hopefully shortly, and be able to get those social media videos and messages as a direct way to influence women and their families and help them quit smoking. So, you know, this is my last slide. By the way, we are still interested to hear from sites for SISTAQUIT. Because, you know, we're still yet to sign up our full amount of numbers. So please get in touch with me if you would like to be interested. But this is just really, we're ongoing looking at scale up funding, trying to get that. And we're partnering with a lot of the health professional colleges for that scale up phase, cancer councils and quit lines. And we've had interest with from universities in SISTAQUIT going into undergraduate midwifery training. So that's all from me today. Sorry, I went a little over. Thanks.
Thank you, Gillian. That's really fabulous. We are very excited about all of that. And now we will hand it back to you to do the next introduction.
Oh, sorry, am I introducing Raglan? Oh, I haven't got Raglan's bio in front of me. Sorry, I didn't realise. Oops, sorry. Have we got a bio you could?
I can probably introduce myself if you like.
Oh, okay. Well, yeah, just very apologies, Raglan, But yeah, well, here's Raglan, and he's going to introduce himself. I'm very excited he could be with us today.
Brilliant. Thanks, Gillian, and great to have this panel, and also wanted to pay my respect to the traditional owners of the land, currently on Ngunnawal and Ngambri country as well. So sharing that land with Tom at the moment. I'll introduce myself throughout the presentation, so the next sort of slide, but I'm going to try and briefly talk about the downward trend continuing in Aboriginal and Torres Strait Islander smoking. So I guess continuing with that NAIDOC celebration discussion, and talk a little bit about the Tackling Indigenous Smoking Program evaluation, which I think will fit quite nicely into to Tom's presentation and Gillian's presentation as well. So I'm Raglan Maddox. I come from the Mottawa clan in Papua New Guinea. I've included a picture here to remind me to do a land acknowledgement and to self-locate, and ended up in Australia when I guess Papua New Guinea became independent. So I have a brother and sister still in PNG, and then 3 nieces and 3 nephews between Queensland and Papua New Guinea at the moment. And I've included this this map. It's Horton's Aboriginal and Torres Strait Islander language map. And the reason I've included this is not only to remind me about acknowledging country, but also to reflect the diversity of Aboriginal and Torres Strait Islander people across the country. I think that's really important. Gillian mentioned the ongoing impacts of colonisation, and we'll speak a little bit about a trauma-informed approach when it comes to smoking cessation and supporting smoke-free behaviours, but recognising the diversity across the country, including urban, regional and remote Australia, is incredibly important if we're looking at client-centred care. As Gillian sort of mentioned or alluded to, and Tom, I work at the Australian National University in the Aboriginal and Torres Strait Islander Health Program, and I head up the tobacco program here, or anti-tobacco program. And the question that we really want to understand or better understand is what's working to improve health and well-being. And there's a number of principles that you can see on the screen there that we base or centre all of our research on, including Indigenous leadership and governance, data sovereignty, community-driven research, partnerships approach, definitely taking a strength-based approach to create change, essentially, and to ensure that future generations hopefully have healthy opportunities and opportunities to thrive. We know that tobacco use is the leading contributor to the burden of disease, and we know that there's widespread awareness of harms among Aboriginal and Torres Strait Islander communities. And that sort of indicates that there is this significant opportunity for change. As you've sort of seen, I guess a constant theme throughout today's session. We also know that commercial tobacco use, or tobacco use as we know it today, is tightly tied in with colonisation. And I think this context is quite important, especially if we think about the trauma-informed approach and putting those clients first, because we quite often forget as service providers that Aboriginal and Torres Strait Islander people were paid in rations of tobacco prior to engagement in the cash economy. And that's in the 1960s. So when I have a focus group or interviews or surveying community members, they will quite commonly say to me, oh, but Raglan, we were paid in rations of tobacco and they were incentivised to value tobacco highly, and now you're taking this product away from me. And so I think that's a very real challenge that we face, and something that we need to acknowledge as a lived experience, which can be quite a challenge. Tom mentioned that the Tackling Indigenous Smoking Program has been going on for about 4 years, and he has been the national coordinator for about 10 years, since 2010. And we're really trying to understand how the tobacco epidemic for Aboriginal and Torres Strait Islander people has changed over that time, and how we can better support the Tackling Indigenous Smoking Program, and obviously create smoke-free or foster an environment for smoke-free behaviours. So we're looking at a whole range of essentially administrative data sets from the ABS, Australian Institute of Health and Welfare. One data set I wanted to mention is the Pharmaceutical Benefit Scheme, so PBS data. And I wanted to mention, for those of you on this webinar, if you're not aware, there is a Closing the Gap PBS co-payment sort of program. So if you're not aware of that, I'd encourage you to do a little bit of research and just find out how we can best support clients to access those sort of services. So we're looking at who's smoking, who's quit, who's staying quit, behaviours related to quitting, to really try and get an understanding of all the impacts that the Tackling Indigenous Smoking program is having on communities. Nick, great question around the boundaries. Just making sure you're listening. One of our first jobs has actually been to map the intensity of the Tackling Indigenous Smoking program. So finding out, as a health promotion public health program, what sort of exposure are clients having? Are they being encouraged to see their GP or the AMS or call the Aboriginal Quit line for support? And we're seeing variations of that over time, over the last 10 years by region. But it is really important to understand that if we are to have informed programs. I mentioned some of the data sets that we're looking at. Another exciting one is My Kuai. For any Aboriginal and Torres Strait Islander people that are on the call today, I'd encourage you to have a look at our website and complete the survey. It's Australia's largest longitudinal study of Aboriginal and Torres Strait Islander wellbeing, and is owned and governed by Aboriginal people, and looks at a whole range of things related to wellbeing, including tobacco use. Then we'll bring all the findings together and share that as quickly as possible. So that's sort of a busy 12 months for us to come. The key message today, if you didn't catch it from the title of the seminar or this presentation, is that we are seeing exciting declines in Aboriginal and Torres Strait Islander tobacco use, similar for both male and female over the last, since 2004. As Tom mentioned, there is regional variation. So here we can see that among urban and regional settings, there has been a significant decline, which we haven't necessarily seen in remote Australia. But I did want to sort of unpack this a little bit. So while that messaging might seem a little bit deficit-based, when we actually start to unpack remote Australia, we have seen changes in the demographic and changes in smoking behaviour, which indicate that there is progress happening and that changes are happening. So we can see across the urban and regional areas that there have been significant declines, particularly in younger age groups, and then no real change or no significant change in the 55 plus. And in the remote regions, we haven't really seen any changes. But I think it's important to also recognise that there has been a shift. This is daily smoking. There has been a shift with daily smoking decreasing and other smoking, so current tobacco use increasing. So we have seen some changes in smoking topography that we will look into. And I think that's quite an encouraging story. So hopefully we've caught up some time. But the good news is since 2004, we've seen a 10% reduction. We've seen almost 50,000 fewer daily smokers today than we would have if smoking prevalence remained the same. And as we know, that sort of translates into many, many lives saved. I've also thought, hopefully we've caught up in time, but I feel like I really whipped through that. There's a couple of papers here that might be of interest that we've undertaken recently, including a review of tobacco use among Aboriginal and Torres Strait Islander people that shows some, which was only published earlier this year, a couple of months ago, which provides some insight into different interventions, evidence-based interventions for supporting smoking cessation. So I think that's a really useful tool, and there's also a summary fact sheet and a video to make sure that's as accessible as possible. And then I cut out some of the methods section because I thought we might be tight on time. So if you want any information on the methods and other aspects of this work, please feel free to have a look at those links. How did we go for time? I think I feel like I nailed that. Time for questions. That's it for me.
That's great. Thank you. Thank you, Raglan. That was great.
Okay. We don't have any questions. It's my turn to introduce Nick Swar for his presentation. Nick is a GP and Executive Dean of the Faculty of Health Sciences and Medicine, Bond University. Professor Zwar has had a long involvement in smoking cessation, including as chair of the Expert Advisory Group for the RACGP publication, Supporting Smoking Cessation, a Guide for Health Professionals. The most recent edition was published in 2019. Nick has contributed to the New South Wales Health Resources Managing Nicotine Dependence and Let's Take a Moment, and was co-chair of the New South Wales Health Task Force on implementing smoke-free policy in mental health facilities. He also led a group developing resources on smoking cessation medicines for the Australian Government Tackling Indigenous Smoking Program. He has led research on supporting smoking cessation in general practice, including evaluating the role of practice nurses. It's my pleasure as tobacco treatment specialist in Northern New South Wales to hand you over to Professor Nick Zwar.
Thanks, Christine. Yeah, and I was asked to talk a bit about use of nicotine-containing e-cigarettes in Australia, and obviously this is a very interesting and topic, and we could spend a lot more time, but I'm just going to try to give a brief overview of data and people in the group may know more about use in Aboriginal and Torres Strait Islander people than I was able to find. I'm just trying to move on the slides, not moving. Maybe Liz, you'll have to do it for me. Go to the next slide. So this is describe the current patterns, how use has changed over time, a bit of comparison to other countries, because that comes up a lot in the discussions and debate. And I wanted to say a little bit about the proposed changes to the Therapeutic Goods Administration arrangements about scheduling of nicotine and the poison standard, because that's quite topical and may be of interest in what that might mean for access to nicotine-containing e-cigarettes. Thanks, Liz. So, well, we all know a little bit about nicotine-containing e-cigarettes, and we also know that they've changed a lot and continue to change rapidly. You know, the older style devices that looked more like cigarettes to some extent have been replaced, particularly in the United States, with things like Juul, which is this little flash drive looking thing you can see here. So it's quite a changing product line, and the amount of nicotine that's delivered has also changed, and increasing amounts of nicotine delivered by the more recent models like Juul, for example. And that may have implications about their how people respond to them, how much they use them, and whether they actually assist with smoking cessation as well. Thanks, Liz. So what do we know about use at the moment? Well, look, I really drew on the recent National Drug Household Survey, which showed that 11.3% over 14s. You know, this survey does a capture of 14 and over, so it doesn't capture really young kids. But 11.3% had ever used e-cigarettes, and most of that was quite infrequent use, like once or twice only, and only 2.5% current use and 1.2% daily use. But if you look back to the 2016 data to 2019, the proportion to ever use e-cigarettes had certainly gone up from 8.8 to 11.3, and the frequency of use amongst smokers had also gone up from 1.5 to 3.2%, and at least monthly from 3.4 to 7.8. Thanks, Liz. So if you look at that graphically, which is probably easier, and this is from their summary report from the National Drug Household Self-Health Survey, you can see 8.8 to 11.3, etc. Lifetime use by smokers gone up from 31% to 39%, and by non-smokers lifetime use from 4.9 to 6.9. So not dramatic changes, but certainly increases in that 3-year period. Thanks, Liz. We drill down a bit more though, and this is probably of interest. If you look at the lifetime and current use of e-cigarettes amongst smokers aged 18 to 39, and then you look at that change from 2016 in the sort of greeny colour to the purpley colour of 2019, you can see that lifetime use amongst current smokers has certainly increased up to 64% now in the 18 to 24 age group, and 54% in the 25 to 29 age group. And in the current use, again, in the 18 to 24 age group, there'd been quite a jump from 6.8 to 18.7. The numbers in the other age groups are quite small, so harder to know whether there's some, you know, how accurate they are, because the sample size gets a bit small. But, you know, that does show some quite substantial changes in that, particularly that 18 to 24 age group, and to extend in the 25 to 29 age group. Thanks, Liz. And this is at older people. Lifetime use had also increased in 40 to 49s and 50 to 59s, and current use as well in those age groups. So, you know, I guess the overall message here is use of e-cigarettes at some point amongst smokers is quite common, and current use is not uncommon. Well, depends on how you describe that, but there certainly is some amongst current smokers, both in younger people and people over 40. Thanks, Liz. Next one. So this is really relying on interpretation from Emily Banks and others at ANU in their recent report, which has garnered quite a lot of attention and some critical attention, as well as some other attention. And they have framed it, as you can see here. So amongst daily e-cigarette users in 2016, so going back to the 2016 data, 32% were also daily smokers, 11% were non-daily smokers, and 38% were ex-smokers, and 18% were never smokers. So going from that, so this is 2016, not the most recent, they've estimated that 43% of daily e-cigarette users in Australia in 2016 were both using e-cigarettes and combustible tobacco. And they've, as some of you would know, have posed that as a challenge to the argument that dual use is fairly uncommon. And they're saying, well, actually on that data, it's not uncommon, it's quite common, at least in 2016. And then you can see 2019, 1.9% reported past use, and 5.2% of never smokers reported ever using e-cigarettes. Thanks, Liz. So if we look at other countries briefly, I'll just look at the United States, and then the next slide will be on England, because I think this is part of the confusing picture about nicotine containing e-cigarettes. Is there seems to be so much variation around the world in uptake. And the United States in particular, there's been quite a lot of concern, as people would know, about uptake in young people. So looking at adults firstly, this is from their 2019 National Health Interview Survey, about 15% of people had ever used an e-cigarette, and 3.2% were current users. So not dramatically high or different to Australia in the adult population, a bit higher. You know, our data was from 14 and over was 11.3 and 2.5 for those two things. So that's not greatly different. But if you look at their use in youth, so this is 2020, so quite recent National Youth Tobacco Survey, just under 20% of high school students and 4.7 of middle school students, so that's their sort of their equivalent of primary, reported current e-cigarette use. And that's quite a difference to our data here in Australia. And you can see that amongst the current users, that nearly 40% in high school reported using e-cigarettes on 20 or more of the past 30 days. So it wasn't occasional use, it was pretty frequent use. And you can see that at that time, and I know that of course US have moved on flavouring since, that over 80% of that was in the flavoured type product. and that was popular both in the high school users and the middle school users. So how much it's the flavourings that attracted these younger people, but it certainly was a factor. And if you look at England, it's quite different. Now, this is a fairly recent thing from Public Health England, 2020, and it's putting together a number of surveys over time. So it's slightly different. Can't say exactly where each of these came from. But current vaping prevalence amongst adults has remained somewhere between 5 and 7%. And so that's in the whole population, adult population. And amongst smokers, it's about between 14 and 20%, and hasn't changed much in the last 6 years. And amongst former smokers, it was up to 13% in 2019. They don't provide what it was in earlier years. And less than 1% of people who've never smoked are currently vaping. Now, currently, of course, is not whether they've ever tried vaping, but currently vaping. And then in youth, it's again stayed fairly stable, about 6% of 11 to 15-year-olds and 5% of 11 to 18-year-olds. But it's notable that it's, you know, in the 11-year-olds, it's about 1%, but it's up to 15% in the 15-year-olds. So it's a bit in the like older kids than the younger kids. But again, less than 1% of young people who have never smoked are current vapers. So not much dual use reported in, not much use reported in non-smokers of either in adults or kids. Okay, so that's a summary. In terms of Aboriginal people, I found something from David Thomas published last year in Nicotine Tobacco Research, which was a survey done from the Talking About Smokes project, and it reported that fewer Aboriginal and Torres Strait Islander people than all Australians had tried e-cigarettes, and that was to some extent thought to be related to less information amongst Aboriginal and Torres Strait Islander people about these products, and it may be a different view about their level of harm compared to the potential harm compared to conventional cigarettes. But others like Raglan or Tom may know more. I just wanted to finish off by just saying a few words about the recent TGA announcements. Basically, this is about rescheduling of nicotine under the poison schedule. And it would move nicotine products, including nicotine-containing e-cigarettes, into Schedule 4, which means that a prescription from a medical practitioner or nurse prescriber would be needed to get access to those on a national basis. And it's quite changes the current situation where the importation of nicotine-containing e-cigarettes or nicotine vaping juice, if you want to call it that, or is variable between states and quite hard for Border Force to actually regulate. And there's been public consultation about this change and considerable debate and input from a range of groups. And I just want to go to the last slide, which kind of shows how it might work from roughly the middle of next year, should this be how things pan out. And what it would mean is that if someone wanted to get access to legally to nicotine-containing e-cigarettes, they would need to have a consultation with a prescriber, usually a doctor, and the RACGP guidelines, which, as mentioned, I was the chair of the expert advisory group, come into this. This is a TGA slide about how the medical practitioner would be guided to assess whether use of nicotine-containing e-cigarettes in order to assist cessation may be a good idea or indicated based on an evidence-based discussion and discussion about the whole range of uncertainties around that in terms of long-term harm and also efficacy. And if there was an agreement between the consumer or the patient and the doctor around that, then there could be a process for the person to get legal access to nicotine e-cigarettes, but only with a valid prescription from their doctor, and the doctor may need to be an authorised prescriber, be the most likely way that this could work. So that has a whole lot of implications for what use of nicotine-containing e-cigarettes might look like in the future should this go ahead. But I think we're out of time, so I'll stop there and hand back to Christine.
Sorry. Thanks, Nick. That's great. At this stage, I suppose what we're looking for is any questions from anyone regarding Nick's presentation. And I think we're just about right on time at 1:31. So Nick, any questions? Are you happy to answer those separately if people send those in?
Yes, that's fine. I see there's a question for either Tom or Raglan. We've got time.
Raglan? Yeah. Raglan, I think it's about regarding remote areas, it appears that the smoking rates remain constant. Are there any strategies for addressing this?
Yeah, I think Tom will also be well placed to answer this. I think it's a challenge that people are facing. I think there's a couple of things. One is that people are cutting back as opposed to necessarily quitting, I guess, is something that we're trying to understand a little bit more of. I think the other hypothesis I have is that people are living longer and continuing to smoke. So that's one of the reasons why we see that shift into older age groups, but still smoking. And I know it has been a focus of the Tackling Indigenous Smoking and others in more recent times to support people to quit smoking. I also think it's really important to mention the context. I know we spoke about colonisation and the ongoing impacts of that. I think there are infrastructure challenges that people in remote communities might face in terms of access to services, but also the social determinants of health and causes of smoking. So if we start to unpack economic and educational opportunities, I think we will see some real improvements in health and wellbeing. But I'll pass on to Tom in case there was anything you wanted to add, Professor Calma.
Yeah, thanks, Raglan. It is a major challenge for us because we just haven't seen with our investment to date any significant changes. Although, as Raglan mentioned in his slides, if you look at the different age demographics, there are movements there. So what are we doing about it? Firstly, out of the TIS program, we funded Dr. David Thomas up in Darwin with AMSANT to work with the Department of Health to look at a mainly Northern Territory remote, because basically all of the territories are remote, to look at different strategies and how to coordinate effort up there. That's one initiative. The other big one is well, it's been delayed actually. It was supposed to happen already this year, but delayed until early next year, where we'll pull together all the teams from the regional or from the remote and very remote communities to have a workshop for a day or two, looking at the different strategies and try and determine what's best practice, what's working, what's not, and what's the best way to go. Because I think we've got to look at a number of issues. One is smoking cessation, which is important, and but you know, you get people who will go out onto a homeland during the wet season and not smoke for 2 or 3 months, come back into an urban or into a regional centre and take up smoking again. So you know, we've got to look at those sort of behavioural issues and see how we work on those. We are seeing progress in the youth, which is good, and I guess the other bit that the other two things we really look at, and it comes on the determinant side of it, are smoke-free homes and getting people to be a lot more conscious about not smoking in homes, the impact of secondhand smoking, etc. Linking it to activities like sporting activities, and making sure if we are going to fund any activities relating to sport or entertainment, then they have to be in smoke-free environments, and that's also working. So yeah, there's a number of strategies that we're looking at, but it's how do we apply it in a more systemic way? And in saying that, we do recognise that across the nation we've got very different groups and different circumstances, and yeah, so it's a real challenge. And the other big one that we have to look at is the economic impact, which goes again to a determinant, because we're in a regional and remote area. The price of cigarettes is exorbitant. It's ridiculous, and you know, people are into poverty, are into stress situations because they don't necessarily have that income to be able to support their smoking lifestyle, as well as the rest of their life situation. So yeah, complex, but we're working on it.
Thank you, Tom. And look, if there's quickly time, there's one for you, Nick. Are there plans for a public health social media campaign targeting young people using e-cigarettes?
Not that I'm aware of, and others like Gillian may have comment here, or Louise. There hasn't been a lot of social media around tobacco or smoking cessation for a while, and that's an issue that we're all, I think, got some concerns about. But I've not heard that that has happened. There's certainly, if this change does happen with availability of e-cigarettes, I understand there will be some funding for education of doctors, and I think there may be, related to that, some social public information, social marketing about the change, but I don't know any detail.
Yeah, and I don't think there is. You're quite right. There hasn't been much funding allocated to date for major education campaigns. There is talk within government to look at trying to address that. There's been a lot of evaluation currently happening on plain packaging, and as the world leaders in this space, we've got to maintain the vigour that we've had in the past, and so it is an issue that we need to be very conscious of and continually lobby government. There are ads out there. A lot of it gets funded out of the TIS program, and the local, and I should recognise some of the broadcasting, and particularly regional broadcasters, who are giving a lot of public awareness support to tackling smoking, and they will provide a lot, albeit late at night, a lot of airtime for good videos.
Thanks, Tom. Well, I think that's our time up. We're a bit over time, in fact, but I'd like to thank all the presenters today very much for your enlightening presentations, and we invite people to send their questions in, and our speakers will respond. So thank you, everyone, today, and thank you, APSAD, for the update. Thank you, everyone.
Yep. Thanks for your interest.
Thanks, everyone.
Bye.
Bye. Bye.
Bye-bye.